Saylor. I'm a neurology consultant at UTH and direct the postgraduate training programs in neurology. And I'm excited to present this lecture entitled Investigating the Nervous System. The goal of this lecture is to help you understand exactly how we utilize the most common investigations that we have for neurological disorders. So when we think about the nervous system from a non-neurologist perspective, we can really break it down into two large parts. The first is the central nervous system. The central nervous system is constituted by the brain, which includes the lobes or the hemispheres, the deep gray structures like the basal ganglia and the thalamus, the brainstem and the cerebellum, as well as the spinal cord. And then in addition to the central nervous system, we also have the peripheral nervous system. So the peripheral nervous system includes the cranial nerves. Remember that these are actually lower motor neurons or peripheral nerves, as well as the spinal nerve roots, the plexi, meaning the brachial plexus and the lumbar plexus, the large name nerves like the femoral nerve or the sciatic nerve, the small fiber nerves that you have in your skin, like those impacted by peripheral neuropathy, the neuromuscular junction, where the nerves talk to the muscles themselves, and then also the muscles themselves are considered to be part of the peripheral nervous system, in that neurologists also care for disorders of muscles like myopathies and myositis. And so when we think of the nervous system, we really think about these two large differentiations, the central nervous system and the peripheral nervous system. And this is important because in general, the investigations that we use to try to localize and find a cause for disorders of the central and the peripheral nervous system are generally different. So if you think about what tests neurologists use to investigate patients with neurological disorders, they really fall into a few groups. So we have neuroimaging tests, which primarily involve computed tomography or CT scans, or sometimes called CAT scans, or magnetic resonance imaging or MRI scans. There are other types of neuroimaging, including PET scans and SPECT scans and some others, but those are really not available in Zambia. And so what we have available to us and what are used most commonly even in higher income settings are CT scans and MRIs. And then we have neurophysiologic tests. So these look at the actual functioning of the nervous system in real time. And primarily these are the EEG or electroencephalogram, and the EMG-NCS, which stands for electromyography, that's EMG, and nerve conduction studies, NCS. A lot of times you'll hear people say that they want to order an EMG, and as we'll talk about later, whenever someone abbreviates this as EMG, they really also are inferring that nerve conduction studies are done as well. These two tests are always done in tandem together and rarely, if ever, done in isolation. And then we have other tests. So of course we have lumbar punctures where we obtain cerebrospinal fluid or CSF for further laboratory investigations, and then serologies from peripheral blood draws as well. So when we think about these groups of tests, let's think about what we can actually investigate with them. So when we think about a CT scan, we really are referring to investigating the central nervous system. So we can get a CT scan of the brain or the spine. It's really not possible to investigate the peripheral nervous system with the CT scan. An MRI is primarily the same in that we usually use it to look at the brain or the spinal cord. However, we can also use an MRI to get images of a plexus, so the lumbar plexus or the brachial plexus, or sometimes even to image a large nerve, such as a sciatic nerve, to look to see if there's a crush injury or a dissection somewhere along the nerve. And then finally, we can also use MRIs of muscles to help us differentiate the cause of muscle disorders as well. So while we predominantly use MRI to investigate central nervous system disorders, there are applications of MRI to the peripheral nervous system as well. EEG, we really only use to investigate the brain. EMG and nerve conduction studies, we only use to investigate the peripheral nervous system. When we do lumbar puncture to obtain CSF, again, we're primarily investigating central nervous system disorders, looking for signs of infection or inflammation, or we can use tests like flow cytometry or cytopathology to investigate malignancies. However, there are some peripheral nervous system disorders that have classic CSF findings as well. So if you think about Guillain-Barré syndrome, which has the classic cytoalbuminologic dissociation, where you see elevated levels of protein in the CSF but no cells. That's a peripheral nervous system disorder where lumbar puncture is one of the standard parts of the investigation. And then there are blood tests or serologies that are available for both central and peripheral nervous system disorders. So now what we're going to do is go through each one of these investigations in detail and its indications and how we apply them to the workup of patients. So starting with our neuroimaging tests. Thinking first about a CT scan of the brain. This study is really ideal for visualizing acute blood and skull deformities. So we're thinking about this in patients with trauma or patients with suspected stroke. You can sometimes see dense space-occupying lesions, such as tumors or abscesses, in the brain of someone. But more often what we see is an area of vasogenic edema, which suggests an underlying infectious, inflammatory, or malignant process. But we may not be able to characterize the actual causative lesion. So we see this area of edema, we know there must be a lesion within the area of edema, but oftentimes it's difficult to visualize the actual lesion itself. And then in general, we get very poor visualization of the infratentorial regions, meaning the brainstem and the cerebellum. There's a lot of bone in that area compared to the relative amount of brain parenchyma. And so there's a lot more artifact in that region, and it's difficult to see abnormalities on a CT scan. You generally will not see small lesions. So for example, lacunar infarcts may never show up on a CT scan. Blood after 7 to 10 days becomes isodense to brain parenchyma, and so you won't be able to appreciate that either. So there are definitely limitations of what a CT scan can show us. And it's important to note that ischemia is often not visible for about 24 hours. And so, as we'll talk about, a CT scan non-contrast is still the test of choice for patients with suspected stroke, even within the first 24 hours of symptom onset. But really what we're putting people in the scanner for is to look for hemorrhage. So we know if they've had a hemorrhagic stroke, because hemorrhage is going to show up immediately, or to look for an obvious stroke mimic, like a space-occupying lesion of some sort. If we put someone who clinically has a suspected stroke into the CT scanner in the first 24 hours and it appears normal, we actually presume that they've had an ischemic stroke that is just not yet visible on the CT scan. And again, as I mentioned before, if you have a very small stroke, such as a lacunar infarct in the basal ganglia or the internal capsule, or a brainstem stroke, we may never see this on a CT scan, even days or weeks later. A CT scan of the spine is able to visualize bones and see any bony injuries, so again, can be really useful in patients with trauma. But the important limitation here is that it really does not visualize the spinal cord in any significant detail. And so if you are thinking about imaging someone who you think has a myelopathy, meaning a problem of the spinal cord itself, a CT scan is going to be a very limited utility and really should not be utilized. You should go directly to an MRI here. So thinking more about MRI scans, in general, an MRI scan compared to a CT scan has a much higher resolution and provides a much greater level of detail. So when I'm talking to patients, trying to explain to them why they already had a CT scan and maybe now we want to proceed to an MRI scan, I compare a CT scan to an old black and white movie and an MRI scan to a new high definition color TV. We're just able to see a lot more and get a lot more detail with an MRI than we are with a CT scan. So one of the major differences is that on an MRI, you can visualize acute ischemia as soon as it happens. There's no delay of 24 hours. We also are able to characterize those small lesions and those infratentorial lesions that are often missed on CT scan. In those space-occupying lesions where on CT scan we might just see an area of vasogenic edema, we usually are able to characterize the lesion within that area of edema on an MRI scan. It's also the imaging modality of choice for spinal cord pathology, as I previously mentioned. Is when you get a CT scan, you really get a non-contrast CT scan, and then potentially you can get a post-contrast sequence as well. On an MRI scan, there's actually several different sequences which can give us lots of different kinds of information. So one of those sequences is called a T1. So this is where your gray matter is going to appear darker than your white matter, and your CSF is also going to appear dark. This is often called an anatomical sequence. It's really great for visualizing normal anatomy or anatomical abnormalities. So here's an example. So again, especially on this coronal section, you can see that the cortex, or the outer layer of the brain, is darker than the subcortical white matter. So gray matter is gray, white matter is white, and we can see in the ventricles that they are dark as well. So this is a T1 sequence. A T2 sequence, on the other hand, is opposite. Now your gray matter is going to be lighter or brighter than your white matter, and your CSF is bright. Now on T1, a lot of pathology will never show up. There's no T1 correlate of a lot of tumors or abscesses and inflammatory disorders. T2 is a much better scan to look for pathology because pathology appears bright. The one downside to T2 is that CSF is also bright, and so it can actually obscure your ability to appreciate the pathology. But it's actually the very best sequence for visualizing pathology in the infratentorial region, which we said is the brainstem and the cerebellum. And so this is an example of what T2 looks like. Again, you can see that the cortex, that outer layer, is brighter than the white matter, which is the subcortical areas. So the cortex, the gray matter, is bright, the white matter is dark, and now the CSF within the ventricles is bright as well. So this is completely the opposite of the T1 scan. The next sequence I want to talk about is a FLAIR scan. It stands for Fluid Attenuated Inversion Recovery sequence. Essentially, what's important is that this is actually a T2 weighted image where the CSF signal is canceled. So your gray matter is still going to be lighter than your white matter. Your white matter is still going to be dark. But now, instead of the CSF being bright, like it is on a standard T2 sequence, the CSF is dark. So now that pathology is still going to be bright white, but now there's less brightness on the scan, and that pathology is going to pop out much easier. And so this is generally the best starter sequence in which you want to look at this sequence first to get an idea of where the pathology is, and then you can use other sequences to help you refine your understanding of what that pathology might be. So this is an example of a FLAIR scan where again now we see that our gray matter, the cortex, that outer layer of the brain, is still brighter than the underlying white matter, but you can see that the ventricles here are dark. So just comparing those three sequences, again on the left, we have our T1 weighted image, which is our anatomical image. Gray matter is gray, white matter is white, CSF is dark. Then that flips for the T2 weighted image, where gray matter is now bright, white matter is darker, and CSF is bright. And then our FLAIR image is very similar to the T2. Gray matter is bright, white matter is dark, but now our CSF is dark, which is similar to the T1 weighted image. So these are really our three core sequences on MRI. There are some additional sequences that can be really helpful, however. So these include the diffusion weighted imaging, or diffusion, and our ADC, which stands for apparent diffusion coefficient. Essentially, these two together are looking at the restriction of movement of water within the brain. And so this is most commonly caused by acute ischemia. So really diffusion and ADC are scans where we look for ischemic injury or acute strokes. Acute ischemia is going to be bright on diffusion and dark on ADC imaging. So here's an example of a left MCA stroke. So you can see on the left image, we have this area of brightness on the diffusion weighted imaging. And then on the ADC imaging, you see that same area of the brain is dark. And so this would be consistent with acute ischemia or an acute ischemic stroke. The final image to talk about is something called gradient echo imaging, or GRE. It's also sometimes called susceptibility weighted imaging, or SWI. And these types of sequences show us blood, and that blood can be either acute or chronic. It does not help us date the blood because acute and chronic blood look exactly the same. The blood appears dark on these sequences, and once it's present, it is always going to show up on GRE and SWI. So essentially, even after the hematoma is reabsorbed over time, and if you look at other sequences, you may not be able to see anything except a scar. You're always going to see that whatever caused that scar had blood in it when you look at the GRE or SWI. The other important thing to note, so first of all, it cannot tell you anything about timing at all, and once the blood is present, it's always going to show up on the MRI because really what it's looking at is hemosiderin deposition, and so even after blood breakdown, hemosiderin is going to remain in that area of the brain, so it will always be dark. The other thing you need to know is about something called a blooming artifact, and essentially because of the technicalities of how these images are obtained, hemorrhages always appear bigger on these sequences than they actually are in real life. So here's an example of a GRE image from someone with cerebral amyloid angiopathy. You can see that they have a large hemorrhagic stroke in their left basal ganglia. But then you also see these sort of tens, there might be, 40 or 50 of these small black circles. These are called microhemorrhages that are scattered throughout the cortex and subcortical regions. So these all represent prior brain bleeds, most of which would be asymptomatic, the microhemorrhages, but then the larger one would be consistent with the hemorrhagic stroke that would bring someone to clinical attention. So then I just want to take a minute to talk about contrasted scans. So for CT scans, we use an iodinated contrast, and for MRI, we use a gadolinium-based contrast. And essentially what happens is when you do a contrasted scan, regardless of whether it's a CT scan or an MRI, a patient goes into the scanner, they have their non-contrasted scans done, then they're pulled out of the scanner, the contrast is injected through their blood vessel, and then the scan is repeated. And the normal response is that the contrast remains in the blood vessels and does not extravasate into the brain. And so because of that, you can use contrast or gadolinium to do either a CT angiogram, sometimes called a CTA, or an MR angiogram or MRA. So this is going to be used to evaluate blood vessel structure themselves. So you can diagnose aneurysms, vasospasm, vasculitis, dissection, or clots in blood vessels based on a CTA or MRA. Alternatively, when inflammation is present, there's breakdown of that blood-brain barrier that is normally intact, making that blood-brain barrier leaky, which means that contrast can then extravasate from the blood vessels and enter the area of the brain where there is blood-brain barrier breakdown. In other words, areas with inflammation will have contrast enhancement. And so these are things like tumors, infections, demyelinating lesions, and subacute strokes where there's tissue breakdown. However, it's important to note that contrast is not indicated for the routine evaluation of stroke. So if you're getting a CT or an MRI because you think someone's had a stroke, a non-contrast image is appropriate. If you're getting a CT or an MRI because you think someone has a tumor, an infection, a demyelinating condition, something else, then you do want to do it with contrast. So we've talked a lot about the ideal way of using an MRI or a CT scan, but we all know that in our setting in Zambia, it's much easier to get a CT scan than it is to get an MRI scan, and it's much cheaper to get a CT scan rather than an MRI scan. And so when should we be using an MRI versus a CT scan? So a CT scan, again, is a scan of choice when you're screening an acute stroke patient. Again, you're primarily looking to determine is this hemorrhage or not. A CT scan in general is good for looking at blood, and it's the scan of choice for patients with trauma, looking for either brain or spinal cord trauma. An MRI, on the other hand, is the ideal test for infections, tumors, demyelinating lesions, and to confirm strokes. It's also the test of choice for all spinal cord disorders and myelopathies. But again, in our reality, it's hard to get MRI scans. And so the truth is, a CT scan of the brain can really give us a lot of information, and it's probably a reasonable screening study for patients that you think have a lesion in the cerebral hemispheres and for whom you have a low suspicion for demyelination. So if your primary concern is an infection or a tumor, then that you think is in one of the cerebral hemispheres, then it's probably going to be an adequate screening test. An MRI, on the other hand, again, should be the initial study for all myelopathies. It should be the initial study for patients that you think have a brainstem or cerebellar lesion, because again, these are poorly investigated on CT scan. And it should be the test of choice in patients with suspected demyelinating lesions as well. So now switching gears to talk about our neurophysiological tests, starting with EEG. So an EEG is really a measure of the electrical activity of the brain. And so because of that, it can give you information about the background activity of the brain that we all have while we're awake and functioning. This is called the posterior basic rhythm. It can also give us an idea about the symmetry of electrical activity in the brain. So is what's happening in the left hemisphere of the brain similar to what's happening in the right hemisphere of the brain? We would expect that normally this is the case. However, if someone has a stroke or a tumor or some other space-occupying lesion in one hemisphere, that should disrupt the normal brain activity. And so we can use it to look for focal abnormalities. In fact, before we had CT scans, neurologists actually used to diagnose stroke using focal slowing on an EEG. In addition, the EEG can obviously tell us about seizure activity. So it can capture ictal activity, meaning that when the patient has the EEG leads on their head, if they have a seizure, we can see the seizure and learn a lot about where the seizure started and potential causes of the seizure. But if they don't have a seizure, we can see what's called interictal activity. And so interictal activity means that these are occasional abnormal electrical discharges in patients with epilepsy that don't evolve into a seizure. But if we see this activity, it tells us that this patient likely has an underlying seizure disorder or underlying epilepsy. So just to give you an idea, this is what a normal EEG looks like. And so it's a little difficult to appreciate, but these lines are essentially grouped into groups of 5. And so the first 5 leads here are coming from the left side of the brain, and they really move from the most anterior lead to the most posterior lead. The next 5 leads are coming from the posterior side of the brain. Sorry, these are actually grouped by 4. So the first 4 are on the left, anterior to posterior. The next 4 are on the right, anterior to posterior. And then again, we go left, again, more posterior this time. And then right-sided leads more posterior. And then at the bottom, we see an EEG lead as well. So what does a seizure look like on EEG? We just saw what a normal EEG looks like with sort of this baseline scribbly line that might look like something a toddler would draw. An EEG, on the other hand, looks like rhythmic, organized abnormalities in which they are generally higher amplitude and generally sharper. So one of my EEG teachers said, if it looks like it would hurt if you sat on it, it's probably a seizure. So we look for that change in sort of the amplitude and morphology or shape of the leads, and then we look to see where those changes are. So what I'm showing you here is a generalized seizure where you can see onset in the entire brain simultaneously. And then what I'm showing you now is a focal seizure, where we can see that in this 4 leads here on the right, so these leads end in even numbers, which tell us they're right-sided leads, we see this abnormal seizure activity. And so again, this is only happening on the right. It's primarily happening in the anterior parts. You can see it a little bit in the bottom right-hand leads as well. But this would be an example of a focal seizure happening in only one part or one half of the brain. So what can an EEG actually tell you as a clinician? So the first thing that it can tell you is the spell that a patient just had while the EEG leads were on a seizure or not? Okay, so if we capture a seizure on the EEG, it can tell us whether it has the characteristics of a particular seizure syndrome, like absence epilepsy or juvenile myoclonic epilepsy, or another particular seizure disorder. It can also tell us, as we just saw, is it focal onset, meaning starting in one part of the brain, or generalized at onset? And then it can also, but what it cannot tell us is whether an event that happened 20 minutes ago was a seizure, because it's only telling us about the brain activity at the time of the recording, not anything that happens before or after the recording is done. Another thing that an EEG can answer for us is the patient in non-convulsive status epilepticus? So remember that some patients will come in clinical status epilepticus, we treat them, we give them diazepam, their seizures appear to stop, and then maybe 6 hours later, they're still not waking up. And the question for us at that time is, are they lethargic or obtunded because of the medications we gave to treat status? Or are they non-responsive because actually they're still in non-convulsive status epilepticus, meaning that their EEG looks exactly the same as it did when they were in clinical status epilepticus, but now there's no clinical correlate of this electrographic status. And so if we put someone who's non-responsive on an EEG, we can look to see if that's because of ongoing seizure activity. Also tell us whether there's evidence of a diffuse metabolic encephalopathy. So these are patients that might be delirious or encephalopathic, and we wonder, is this non-convulsive status or is this an encephalopathy? Again, we look at the frequency of that posterior basic rhythm, that normal background rhythm, and if it is generally slow throughout the recording, that's suggestive of some sort of metabolic disturbance rather than an epileptic disturbance. We can look for evidence of focal pathology, again, asymmetry between the left and the right sides of the brain that might suggest an underlying space-occupying lesion. And then we can look for evidence of interictal discharges, these abnormal electrographic discharges that can be seen in people with epilepsy that are not seizures, but tell us that that person has an underlying predisposition to having seizures. And where brain death is recognized as equivalent to cardiac death, which it currently is not in Zambia. But in countries where that is the case, we can look for whether a patient meets brain death criteria, meaning is there any electrical activity ongoing in the brain, or has all electrical activity in the brain ceased? And an EEG can answer that question for us as well. So we learned what an EEG can tell us, but I think it's just as important to understand what an EEG cannot tell us. Because oftentimes I see clinicians all the time, a patient presents with a seizure and the automatic thing is, well, this patient needs an EEG. And the truth is that's not true. And so what does an EEG not tell us? So again, an EEG cannot tell us if the event a person had yesterday was a seizure, or even an event, whether an event the person had 5 minutes ago was a seizure. It's only going to tell us about the brain activity at the time of the EEG recording. So remember, seizures are a clinical diagnosis, and an EEG is not like a blood test that says yes, no, a patient has epilepsy or not. And importantly, people with epilepsy can have completely normal EEGs. So remember, we only do EEGs for 20 to 25 minutes, and it is totally possible for someone with even severe epilepsy to have normal brain activity for 20 minutes. And so a normal EEG does not exclude a diagnosis of epilepsy. And this is really, really important. And so if an EEG does not tell you for sure whether or not someone has epilepsy, who needs an EEG? So if you're making a diagnosis of epilepsy for the first time, it's reasonable to get an EEG. One, because if you see interictal discharges, again, the morphology, the frequency of those discharges might give us an idea of whether seizures are focal onset versus generalized onset, which can help us guide our selection of which anti-seizure medication we're going to treat them with. And it can also tell us whether a particular epilepsy syndrome is present, which may also guide our selection of medications. We also get EEGs in someone with epilepsy who's been seizure-free for at least 2 years on anti-epileptic drugs, and maybe we're considering stopping their medication. Because if we get an EEG and we see that there are still interictal discharges, then that tells us that we'll likely need to continue the medications because that patient is still at really high risk of having seizures if they come off the medications. If we get the EEG and it's normal, it makes us feel better about a trial of stopping the medication, but it does not guarantee that a patient won't ever have a seizure again. The EEG may be normal because the seizure medications are keeping it normal, and when we stop the medication, then the seizures may return. But there's really no way to know for sure whether or not someone who's been seizure-free for some time has truly outgrown their epilepsy, or whether it's just really well controlled on their medications. But the EEG can at least help you to screen out people in whom you definitely should not stop their medications. Alteration of consciousness in whom you're considering non-convulsive status epilepticus also needs an EEG. Again, this could be someone who presented with convulsive status, we treated them, the seizures resolved, but they're not regaining consciousness. So is it a medication effect or are they in non-convulsive status? The EEG can answer that question. Someone with no history of seizures who's presenting with altered consciousness, and based on your history and exam, you think they could have an ongoing process that could cause seizures. Again, they could be in non-convulsive status, and an EEG can tell us whether their altered mental status is from non-convulsive status or something else. This talk of non-convulsive status is really not theoretical. It's really important for us to have this on our differential. So this is a research study from a few years ago that took place at UTH. And essentially, they screened everyone with a GCS of 9 or less who is admitted to the medical wards, and they did a 30-minute EEG. And what they found was that actually 20% of those patients on our medical wards at UTH with a GCS of 9 or less had suggestions of non-convulsive status on their EEG. So this is a highly prevalent condition in our setting, one that we can treat and that can make a huge difference in patient outcomes. So it's something we need to think about, especially in the inpatient setting. So finally, ideally, prolonged EEG monitoring can be useful for determining if spells that someone is having are epileptic or non-epileptic. So if you're thinking about psychogenic non-epileptic spells or pseudo-seizures, if you can capture one of those spells while the patient is undergoing EEG, it can tell you whether there's an electrographic correlate, meaning this was an epileptic seizure, or whether there's no electrographic correlate, meaning it was a non-epileptic spell. Ideally, this is done in units called epilepsy monitoring units, where patients are actually admitted to an inpatient setting and they wear an EEG for 5 to 7 days continuously. This certainly increases the chance that you're actually going to capture a spell. In our setting, we're not able to do that, so we're really still limited to these 30-minute EEGs. But if we happen to capture a spell while they're wearing the EEG leads, then it can answer that question for us. So again, importantly, who does not need an EEG? So a known epileptic patient who presents with a breakthrough seizure and is now back at their baseline, an EEG is not going to help us in any way. We already know they have epilepsy, and so a normal EEG is not going to make us think they don't have epilepsy, and an EEG that shows interictal discharges is already going to confirm what we already know, which is that they have epilepsy, and they're back at their baseline, so there's no concern for non-convulsive status. So someone, again, a known patient with epilepsy presents with a seizure, now back at baseline, really does not need an EEG. And then again, someone who presents with their first time seizure, they're back at their baseline, and we already know the cause of their seizure. So they've had a CT scan and they have a new diagnosis of a brain tumor, or they have a tuberculoma, or they have neurocysticercosis. We've already found the cause of their seizure. We clinically know they had a seizure, and EEG is not going to change our management in these patients in any way. So moving on now to talk about EMG and nerve conduction studies. So we'll start with nerve conduction studies. So nerve conduction studies are electrical studies in which we look at both motor nerves as well as large sensory nerves. So nerve conduction studies are not able to test small sensory nerves, which are the ones most commonly involved in distal symmetric peripheral neuropathies or small fiber neuropathies. So how are these tests done? You can see here this little device that someone is holding and placing it over the course of the median nerve. So this is a device that provides a small electrical impulse. We put the device over where we know a nerve runs. And then what we do is we put recording pads. You can see the stickers on this patient's palm. We put recording pads over the muscles that we know that the nerve we're testing innervate. And so what we end up doing is we provide a small shock to the nerve. That shock or electrical impulse is then conducted to the muscles that it innervates, and those recording pads record when that stimulus makes it to the muscle. And so by knowing the time between when the impulse is given and when it is recorded, and by knowing the distance between where the impulse is provided and where the impulse is detected, we can then calculate several things. So what can we learn from nerve conduction studies? The first thing we can learn is what percentage of an electrical signal is reaching the target. And so you can see this in panel A, where we see the green is the shock that is given by the recorder, and then the blue is what is recorded at the recording pad. And so the normal response is that however much electrical signal is presented to the nerve is also detected later on. And you can see that if there's a conduction block, meaning there's a problem in the nerve that's preventing passage of the electrical signal, then you are not able to detect as much signal as you would expect. And so this is really telling us, is there a structural problem that is blocking the signal from passing through the nerve? We can also then look to see how quickly does the signal reach its target. So this is shown in panel B, where we're looking at conduction velocity. So when we give the signal, how quickly is it detected? And if it takes longer than normal, that tells us that there's a problem with the myelin. So remember that myelin is that insulation that covers our myelinated axons, and it helps to conduct the signal more quickly. And so if there's a delay in the velocity, it tells us there's a problem with the myelin, or there's a demyelinating neuropathy. And then finally, we can look at how large is the signal that's reaching the target. And so that you can see in panel C. And if the signal is reaching the target in the right amount of time, meaning the velocity is okay, the myelin is okay, but the amount that's reaching is smaller, that tells us that there's a problem with the axon, that we have an axonal neuropathy. And so the other information that nerve conduction studies give us is what kinds of nerves are affected. We can test both motor and sensory nerves. So we can see, is this primarily a motor neuropathy? Is it primarily a sensory neuropathy, or is it a mixed neuropathy? Again, it can tell us, are we looking at an axonal process or a demyelinating process, depending on whether the amplitude or the velocity of the impulse is affected. And it can tell us the pattern of involvement. Is it symmetric or asymmetric? Is it length dependent, meaning the longest nerves are affected but shorter ones are not? Or is it non-length dependent, meaning it's sort of random what's affected? And based on what nerves are affected, it can help us to localize, is this a radiculopathy, a plexopathy, or a neuropathy as well? So nerve conduction studies gives us a lot of information about the peripheral nerves themselves. An EMG is then the second part of the test that we do, which is essentially a needle study of the muscles in the neuromuscular junction. And so what happens with this is that a very small needle with a recorder is inserted into a muscle. The patient is asked to then activate that muscle, and we record the electrical activity that happens during muscle activation. And so what information does this give us? Again, an EMG is a very subjective test that requires a lot of training to interpret. So I'm not going to show you the morphologies themselves. This is for somebody who really is going to be doing EMGs to know. But if you're ordering an EMG, you need to understand what the reports mean and what information you can expect the EMGer to give you. And so one question that an EMG can answer is muscle weakness myopathic, meaning is it primarily a problem of the muscle, or is it neurogenic, meaning it's primarily a nerve problem? And if it is a myopathic problem, is it an inflammatory problem, meaning a myositis, or is it a non-inflammatory problem, meaning a myopathy? An EMG can also give us an idea about whether the problem is acute or chronic. And it can also assess the neuromuscular junction. So we do this by doing repetitive stimulation of the same muscle and looking at the muscle response and looking for evidence of a neuromuscular junction disorder such as myasthenia gravis or Lambert-Eaton syndrome. So who should have an EMG? Anyone with a disorder localizing to the peripheral nervous system, with the exception that people with a standard distal small fiber sensory neuropathy should not have this. So these are generally going to be people that have a known cause, such as a diabetic neuropathy, an alcoholic neuropathy, HIV-associated neuropathy, someone with chronic kidney disease, something like that. And again, the reason for this is that the nerve conduction studies are assessing large nerves. They're not assessing the small fiber nerves that are affected in your standard peripheral neuropathy. Who does not need an EMG? Again, anyone with an examination localizing to the central nervous system. And so remembering back from your lecture on myelopathies, this is going to include people who present with a flaccid paraplegia but have signs of CNS involvement, such as an upgoing toe, bowel or bladder involvement, or a spinal sensory level. So switching gears quickly to talk about our other studies, meaning CSF and serology studies. So CSF studies can be used to assess pathology that localizes to the brain, the spinal cord, the meninges, or the nerve roots themselves. And primarily we're thinking about looking for signs of infection, utilizing the cell count, protein, and glucose pattern to help us think about the category of microbiological diagnosis that we might be thinking about, meaning that a bacterial infection has a different profile than a fungal or viral infection. We can also utilize cultures to try to identify the exact etiology, as well as PCRs and antigen testing for the same purpose. If we're investigating a malignancy of some kind, we can use flow cytometry and cytopathology. And if we're looking for an inflammatory or autoimmune disorder, we can use cell counts, proteins, the IgG index, and oligoclonal bands to help us better characterize that disorder as well. For serologies, there are some neurological disorders that have associated serum antibodies. So this includes NMDA receptor antibodies like for anti-NMDA encephalitis, aquaporin 4 antibodies for neuromyelitis optica, and also myasthenia antibodies as well. So just briefly, a couple of cases to think through to see if we can apply what we've learned. We have a 52-year-old woman with a past medical history of HIV, hypertension, and diabetes, presents with the acute onset of right-sided weakness and cessation of speech. And so the question is, what study would you order and why? So I would suggest that you pause here and think about it before you proceed. So the answer is that a CT scan would be the test of choice because we are suspecting that that patient had a left MCA stroke, which is a large stroke involving the hemispheres. And again, the CT scan is the test of choice for all patients with suspected stroke. For this case, we have a 39-year-old man with newly diagnosed HIV presenting with a 2-week history of being unable to walk. He reported ascending numbness and weakness over the past 2 weeks and also has developed urinary retention and constipation. On exam, he has a flaccid paraplegia with areflexia. And so the question is, what study are you going to order? Again, I'll let you pause and think. So to answer this question, we first have to think about localization. The flaccid paraplegia and areflexia might suggest a peripheral nervous system disorder like Guillain-Barré syndrome, but we've been given the extra information that he has urinary retention and constipation. And this really only happens with myelopathy. So this is more likely a spinal shock syndrome, making the patient flaccid and areflexic, which is not typically associated with central nervous signs, but can happen in the acute setting. And so the urinary retention and the constipation really push us from a peripheral nerve localization to a spinal cord localization. Because we think this is in the spinal cord, then our test of choice is going to be an MRI of the spine. And so again, this demonstrates how essential it is that you first localize before you generate your differentials and before you order your investigations to ensure that you're ordering the appropriate test for the patient. This case now is the same case, except there are no bowel and bladder symptoms. The patient still has a flaccid paraplegia with areflexia and the toes are down going. And so go ahead and pause again while you think about what study you're going to order. For this patient, we first again do localization, and this time there are no symptoms or signs to suggest an upper motor neuron or central nervous system process. And so our localization here is really to the peripheral nervous system. And so because of that, our test of choice is going to be EMG nerve conduction studies. Likely this patient would also need a lumbar puncture as part of evaluation for Guillain-Barré syndrome as well. Case is a 24-year-old woman with no past medical history who presented with status epilepticus. She was given 10 milligrams of IV diazepam as well as 200 milligrams of phenobarbital and her seizure stopped. You're now seeing her the next day and she's still minimally responsive. And so what test would you want to order? So again, I'll let you pause and think about the answer. So here, based on the history, we'd be worried about whether she's in non-convulsive status epilepticus, and so she should have an EEG test done. This is a bonus question. This is a 30-year-old woman with no past medical history who presented with left eye pain and vision loss. On history, she reports a prior episode of right foot drop 2 years ago and a 2-week episode of severe vertigo 1 year ago. Her exam is notable for a left afferent pupillary defect, increased reflexes in the right leg, and an upgoing toe on the right. And the question is, what study would you order? Again, I'll let you pause. So again, here we first have to think about localization. And in this case, there's not one unifying localization. So her current presentation with painful vision loss in one eye suggests an optic neuritis localizing to the optic nerve. A right foot drop 2 years ago could suggest either a peripheral or central process of either the spinal cord or one of the hemispheres itself. An episode of vertigo 1 year ago suggests probably a brainstem lesion. And then with the increased reflexes in the right leg and the upgoing toe on the right, that really suggests that her foot drop was due to a central nervous system problem, again, potentially in the spinal cord or in the brain. And so we're really looking at a multifocal central nervous system disorder affecting the optic nerve, the brain, and potentially the spinal cord. And so in a young woman with multiple recurrent episodes of focal neurologic dysfunction localizing to multiple places in the central nervous system, the leading differential would be a demyelinating disease such as multiple sclerosis, neuromyelitis optica, or MOG antibody-associated disease. And if we're thinking about demyelinating diseases, a CT scan will not be sufficient. And so this patient would need an MRI of the brain and probably the spinal cord as well. So I hope that this has been a useful lecture and has given you some insight into how we utilize common diagnostic tests for neurological disorders, how we think about what we can and can't learn from these investigations, and also has reminded you of the importance of localizing a patient's suspected disorder, meaning using the information from your history and exam to localize where you think the problem is before you decide on what investigations to order. Thank you so much for your attention.